Good evening. Let's start our lectures on chronic pain with emphasis on the psychosocial and economic aspects of chronic pain. So we will follow this outline. Definitions, we'll look at differences between acute and chronic pain. We'll look at some common chronic pain disorders. We'll talk about social effects of pain. We'll look at the economic effects also. And then we'll talk about the management of chronic pain. All right, chronic pain is defined as pain that is extending beyond the expected temporary boundary of tissue injury and normal healing, and adversely affects the function and well-being of the individual. This definition of chronic pain by the American Society of Anesthesiologists covers the whole aspect of chronic pain. It talks about the boundary of tissue injury where you expect your pain to be localized. It also talks about the normal healing period, which is exceeded with chronic pain. And one aspect of chronic pain that makes it different from acute pain is that it affects the function and well-being of the sufferers. So chronic pain, this definition is very extensive, and chronic pain may also be defined as a constant or intermittent pain that persists beyond the expected healing time. It is not usually associated with any specific cause or injury type. And like we said before, it usually lasts more than 6 months. Some studies have shown that even in critically ill patient admitted to ICU, poor management of pain in the ICU can lead to the development of chronic pain up to 6 months after discharge from ICU. So chronic pain is very broad. It affects every aspect of the patient's life and well-being. All right, so we continue. We quickly look at the differences between acute and chronic pain. This is one of the common questions I like to ask because you need to know the differences. On the left side of the screen, you'll see the differences between acute and chronic pain in terms of onset and timing. Acute pain usually is sudden and is of a short duration, while insidious in onset and usually lasts longer beyond the expected period of healing. In terms of signal, acute pain has a warning sign of actual or potential tissue damage, while chronic pain has no warning signal of damage, or it may actually have a false alarm. In terms of severity, the severity of acute pain correlates well with the amount of tissue damage, while that of chronic pain has no correlation to tissue damage or even the presence of tissue damage. In acute pain, the central nervous system is intact, and here acute pain is just a symptom. On the other hand, chronic pain is the disease itself. Chronic pain is a disease entity as it causes dysfunction of the central nervous system. In acute pain is not associated with anxiety or lack of sleep. In actual sense, relief of acute pain leads to improve sleep. While in chronic pain is associated with depression, fear, and anger. And that's why we're talking about the psychological effects of acute pain today. Note also that chronic pain may have started from an illness or injury from which the patient has long since recovered, but the pain has remained. For instance, a surgical pain and an example of acute pain is post-op pain. All right, when the wound has healed, you expect the pain to subside. But in case of chronic pain, the pain persists long after healing has taken place. And in other causes of chronic pain, all right, there may be an ongoing cause of pain, such as arthritis, inflammatory reactions, or tumor cells growing. In addition, people may suffer chronic pain even when there is no obvious sign or evidence of past illness or injury. So the question that you may want to think about is, what is chronic pain? Compare and contrast acute and chronic pain. All right, we are in the era of imaging, and some scholars have taken upon themselves to look at the brain of suffer chronic pain and compare with those who have acute pain. And it's been found out that the physiological processes in chronic pain is more complicated than what is seen in acute pain. Whereas in chronic pain, there's the presence of ongoing pain, and chronic pain have, diverse modes of drug and other types of therapy which affects the imagings of the brain. Pain intensity for spontaneous chronic pain and interval pain are actually encoded in different brain regions compared to where acute pain is. All right. So pain intensity of thermal pain in both chronic pain patients and normal subjects is best correlated with right insular activity, which encodes the nociceptive information. And it was found out also that chronic pain may be considered a driving force which causes a change in cortical anatomy and physiology. And this established the mindset of chronic pain in the sufferers. So the imaging of chronic pain shows a different anatomical and physiological patterns as compared to acute pain. Common chronic pain disorders, we have arthritis, which could be osteoarthritis, rheumatoid arthritis, or psoriatic arthritis. Now, it's been found out that there are some specific and anxiety disorders, all right, which seem to occur more among those with arthritis compared with those who don't. Another example of chronic pain disorder is the fibromyalgia, which is a chronic multi-symptom disease where the brain and the spinal cord process pain signals differently. In this patient, pain is processed very differently. All right, so it's more of a problem of the brain. Fibromyalgia is associated with widespread pain in the muscles and bones, with areas of tenderness and general fatigue. Note that it's been found that the rate of anxiety disorder is about 5 times higher in women with fibromyalgia than in the general population. Other chronic pain disorders include multiple sclerosis, and it's been found out that the 3 common mental health concerns with multiple sclerosis include depression, anxiety, the bubble effect. In fact, it's been documented that people with multiple sclerosis are nearly twice as likely as those without it to experience MDD, major depressive disorder. We have back and neck pain, all right? And here mental health conditions are also common. We have chronic migraines. And these are headaches that last more than 15 or more days in a month in the 3 consecutive months. All right. Migraine usually is associated with mental health conditions, as we'll look at it. Menstruation related pain. All right. While pain is normal in some types of period in some women, conditions like endometriosis and uterine fibroids can make menstrual pain very debilitating. So let's go down to the meat of our discussion this evening. We're looking at the psychosocial effects of chronic pain. And I've summarized it under the word chronic in case you are asked. All right, just write chronic and we'll go over the mnemonics together. C represents cognitive impairment. All right, H, we're talking about health challenges like we mentioned previously, anxiety, depression. Chronic pain takes its toll on relationship. Others such as anger and irritability. Patients with chronic pain have low quality of life. They're actually associated with loss of sleep or normal sleep patterns, and they can have concentration memory loss. So I've just tried to summarize the psychosocial aspects of pain, and like the likely question you may get is enumerate the psychosocial aspect of pain, and I can just pick one or two to say explain how does chronic pain affect quality of life. So let's go deeper about the effects of chronic pain on cognitive abilities of the sufferers. Now, chronic pain negatively affects cognitive ability, and this is because persistent or intermittent prolonged pain causes changes in the brain system that control cognitive function. You remember we talked about the imaging in the brain of chronic pain patients. And the effect of this, the anatomical and physiological changes in the brain leads to what we know as a cognitive error. A cognitive error is defined as a negatively distorted belief about oneself or one situation. It's a negatively distorted belief. All right, some persons with chronic pain may think they have been obsessed or they have been oppressed by demonic powers. And it is a cognitive error that is due to the presence of persistent or intermittent pain. And some of these cognitive errors include catastrophizing, which, it is when a normal event is being misinterpreted as a catastrophe. You hear some people say, this headache is catastrophic. I can barely do anything when it comes. Is what we call catastrophizing a condition that is normally as catastrophic as it should be. The second cognitive error that may occur with cognitive impairment, second to chronic pain, is what we know as personalization. All right, when the patient begins to take responsibility for the pain that is having. Oh, it's because I didn't do this, it's because of this, it's because of that. And then we have what we call selective abstraction. All right, we selectively attend to the negative aspect of a situation. Instead of looking at the good aspect of it, they are concentrating on the negative aspects of pain. So, three cognitive errors that define the cognitive impairments in chronic pain are catastrophizing, personalization, and selective abstraction. The second psychosocial effect is the health challenges that chronic pain sufferers usually have. All right. The link between chronic pain and depression is strong. All right. And it seems to be that there's a significant relationship between those who have chronic pain symptoms and the incidence of depression. In fact, some of them, the pain can be so perceived to be catastrophic that they begin to entertain suicidal thoughts. All right. It's been said that people with chronic pain have at least twice the risk of suicidal attempt than those without chronic pain. And chronic pain sufferers are also 4 times more likely to have depression or anxiety than those who are pain-free. All right. And it's a roller coaster. Patients with more symptoms also seem to have increase of pain problems. So chronic pain leading to health challenge like anxiety and depression. And patients who are anxious and depressed tend to have increased perception of pain. A meta-analysis by Blair et al. Suggested that the pain reporting by patients chronic with depression range between 15 to 100%, with a mean value of 65%. So patients with depression seem to almost always report pain and catastrophize the pain intensity that they have. The third one is chronic pain and relationship. Like I mentioned before, pain is linked to emotions. In fact, chronic imaging of the brain of chronic pain sufferers shows that physical pain and emotions seem to exist on the same psychiatry of the central nervous system. So as a result, chronic pain is often associated with emotional challenges, which impacts negatively on relationships. Marital conflicts, problems with spouse and all that. And all of this tends to lead to depression. All right. Strom and Bodin in 2004 actually have reported marital conflicts, which include decreased sexual relationship and less marital satisfaction, all due to the presence of chronic pain. Chronic pain and others like anger, irritability, elevated levels of easy irritability, things that normally shouldn't make someone irritable, have been reported among those who are suffering from chronic pain. All right, irritability and frustration may be directed towards the pain condition itself, may be directed to the clinicians or physicians for failing to find solutions to their problem. It may be directed to the employers. It's because you made me sit for 6 hours in a day that I'm having this chronic back pain. And worst of it is that it may even be directed to the patient itself, personalization that we mentioned before. All right. And like I said, it also be directed to anyone, all right, around them, family members, co-workers, neighbors, church members, all of that. Easy irritability. So maybe we need to be gentle to people we see around because they may be undergoing some pain and make them susceptible to anger, flaring up, and easy irritability. And these are common experiences in our day-to-day life. All of this sum up to the fact that chronic pain will lead to low quality of life among the sufferers. All right, because there's always a consistent perceived threats, which will lead to increased awareness, increased self-awareness out of self-protection. They perceive that anything can aggravate their pain, so they are more defensive. All right, and some of them have low, low desires for outdoor activities. All right, some of them do not even want to go to work anymore because they're trying to protect themselves from anything that will aggravate the pain. All right, a study, by Hardy and colleagues compare patients with chronic pain and the general population. and reported that chronic pain patients have significantly lower mean quality of life scores across all domains. All right, with a very significant statistical findings. In all of this, quality of life systems emerge from the study, all right, which involves interference with physical functioning, interference with professional life, interference with relationships and family life, interference with social life, interference with sleep, and even interference with mood, with subsequent mood changes. All of this summed together seem to produce very low quality of life among patients suffering from chronic pain. And we know the relation between comfort and sleep. So when there's the presence of constant pain, this will lead to sleep disturbances in terms of pattern or even the duration of sleep. All right. Chronic pain can lead to sleep disturbances, which may be characterized by longer sleep onset. Patient doesn't fall asleep, soon enough, and they tend to wake up more. They have short time of sleep, and their sleep is not refreshing. And this all sums to poor sleep quality. All right, such patterns may actually lead to what we call primary insomnia. And sometimes when we see patients who are suffering, who are having difficulties with having refreshing sleep, the underlying factor may just be chronic pain. And managing the chronic pain may just be as well as what they need to take care of their insomnia. It's been found that 50 to 80% of patients with chronic pain experience ongoing sleep disorders, difficulties. All right, the National Sleep Foundation in the US suggests that 2 out of 3 people, that's a lot, 2 out of 3 people with chronic pain have trouble sleeping. And one of the commonest chronic pain disorders that affect sleep pattern is obviously chronic back pain. All right, most problems with chronic pain is that chronic pain has been linked to short-term memory issues. All right, this may be due to lack of attention, reduced spatial memory, recognition memory, and even decision making. In Canada, a study among chronic pain sufferers found out that patients performed worse on memory tests, all right, when they didn't take their pain relief medications or procedure. They noted that the result didn't seem to be linked to other factors such as age or sleep or stress. The determining factor was more of pain, chronic pain, presence of chronic pain. And when these patients were subjected to memory tests, they found out that they performed very unsatisfactorily. Yeah, so economics of chronic pain, I just felt there are 2 lectures in one. I just felt that we should just link them together. After talking about the psychosocial effect, we'll just quickly look at the economics of pain. Look at this question. What do you understand by the term pain is expensive? Do you agree that pain is expensive? Not just in the management or treatment of it, but in a lot of other factors that impact on the economic situations or the economics of chronic pain. All right, so chronic pain poses a significant economic burden for patients, the healthcare service itself, and the societies alike. So it represents a significant burden, especially in middle and low income countries. All right, because it places additional burden on the limited healthcare resources. The economic impact of pain is greater than most other health conditions that you may think of, because it affects, increases the rate of absenteeism from work, reduced levels of productivity, and increased risk of leaving the labor market. So the patients stop working and become dependent on the social security system. or dependent on other family members which already have their economic burden. So all of this put together is summarized in this phrase that pain is expensive, much more than the groceries whose prices have been going up. So some of the consequences of economic consequences of chronic pain is that it puts a lot of pressure on payout, economic increased medical expenses by medical aid organizations and social security scheme. All right, a lot of claims and compensation for payments being entered into yearly from regions where studies are conducted indicate that most of them are due to compensation of payment from chronic pain sufferers. All right, there's loss of income, loss of productivity, and there's increased legal charges. All of this constitute what we know as the economics of chronic pain. So let's look at loss of income, for instance. In Sweden, the loss of production due to sick leave resulting from chronic pain was estimated to constitute about 91% of the socioeconomic cost of 7.37 billion pounds. All right? And this was associated with loss of production in 2003. In a US study, I think we need to do a Namibian study or an African study to actually look at the impact of chronic pain on loss of income and what we know as the economic effects of chronic pain. In the US, there's a study that looked at the effect of pain, and in particular pain exacerbation, and found out that the impact of arthritis in economic terms was about 3.76 billion. In Denmark, it's been estimated that 1 million working days were lost annually. 1 million working days were lost collectively as a result of chronic pain. All right, and these all end up with loss of income, which affects the individual, his dependents, and the society at large. Obviously, it makes sense that somebody who is suffering from unrelieved pain cannot be at his maximum. Right, so chronic pain has a great impact on absenteeism. I'm sick today, I'm sick tomorrow. All right, even people who are present but are not productive, presentism. All right, I remember those days, one of my what they call it, mentors used to use this word, physically present but intellectually absent. All right, many people with chronic pain may actually force themselves to work, but they're intellectually absent, although physically present. All right, and this chronic pain has a profound effect on people leaving the labor market. All right, it's been reported that the odds of quitting one's job because of ill health have been shown to be 7 times higher among people with chronic pain. In addition, one study also had reported that 74% of people with high impact chronic pain are presently unemployed. They are out of the labor market. Compensation of payments. Chronic pain resulting from low back pain and chronic pain syndrome has been identified as one of the health conditions most clearly associated with disability benefits. Filing of claims. In fact, in the UK itself, this chronic pain complaints comprise about 50% of sick leave, for which they are paid anyway. So that's the compensation of payment we're talking about, especially from health insurance and all that. We say chronic pain is expensive, not only to the individual, but also to the healthcare services. All right, and an analysis of a Canadian database demonstrated that cost of healthcare resources were significantly higher in patients with painful neuropathic disorders. all right, even when this was matched for age and sex. So we can see that chronic pain is not just somebody saying that my pain is not going away, all right? It has both psychosocial and economic effect, increasing, all right, the total, all right, needs that needs to be given to these patients. All right, so the principle of management of chronic pain revolves around setting your goals. All right, you know, the goal is not about cure because, like we established earlier on, a lot of times chronic pain does the absence of a causative injury or illness. So if you want to cure the pain, you may be chasing shadows because a lot of times healing has even occurred, but pain persists. So what we're trying to do is make sure you set attainable goals, which is improving the pain that the patient suffers. If the patient has a pain score of 10, you want to reduce it as much as 4. But it will be delusional to think that we'll take the pain away or we'll cure the patient. We want to decrease pain intensity and reduce suffering. We want to also improve as much as possible activities of daily living and thereby improve the quality of life of this patient. There are management options directed to the management of chronic pain. It could be pharmacological. As anesthetists, we're familiar with this. It could be non-pharmacological. But I'm going to dwell more on the psychological management of chronic pain because as clinicians, we often neglect these very important and pivotal management options for the management of chronic pain. Like I mentioned, we all know this pharmacological, your normal NSAIDs, opioids, antidepressant, anticonvulsant, steroids, the use of local anesthetic agents. I'm not going to dwell on that. We all know that, especially from our lectures on pain. Non-pharmacology management also quite familiar, all right, with a graded exercise program to improve joint stiffness, muscle atrophy, and contractures. We have the superficial heating methods such as hot packs, paraffin. Then we have the acupuncture, TENS, and all that. So we'll talk more about the psychological methods of managing chronic pain. The question here is, enumerate 5 psychological methods of managing chronic pain. All right, so we have the first one is self-management techniques. The patient, you want to get the patient involved in the management of his or her pain. And this includes cognitive therapy, relaxation, biofeedbacks, and hypnosis. In all of this, cognitive therapy is important because it gets the patient involved. And what it does is that it tends to change the patient's attitude towards pain, perception of pain. This is important. Cognitive therapy is geared towards trying to turn the patient's attitude towards pain around. And this has been found to influence the perception of pain. All right, cognitive therapy involves provision of preparatory information, telling the patient what you want to do and all that. And you do what we call, you begin to present the cognitive coping skills, just like distractions, attention diversion, especially when the pain comes and all that. They're taught to distract themselves from the pain instead of paying so much attention to the pain, doing something that the patient likes. All right, these are cognitive therapy that has been found to improve the pain relief. All right, the second self-management technique is what we know as the biofeedback technique. All right, The patient's information are fed into a control system which provides a biophysiological feedback to the patient about how his body works or responds. All right, and it's been found out that this helps the patient. For instance, when you pay attention to this pain, your heart rate increases, your saturation drops, you are starting your vital organs of oxygen. And when they see this on the screen, on the monitor, all right, it helps them to say, no, I don't want to cause more damage and all that, because this helps to give them a feedback of what paying attention and perception of their pain does to their physiological makeup. We have two types of biofeedback techniques, and both of them have been shown to be helpful in the reduction of a wide range of chronic pain conditions. These are peripheral biofeedback and neurofeedback technique. All right, the other one is what we know as the behavior technique or the operant technique. All right, this is based on the fact that the behavior of patients with chronic pain is determined by the consequences of that behavior. Let me repeat this. Operant or behavior technique is based on the fact that the behavior of patients with chronic pain is determined by the consequences of those behaviors. Some of them, when some people are around, they feel increased pain just to get attention. All right, when people who pay attention to them, all right, are around, they tend to, have intense, the intensity of their pain increases. And as long as such persons are around, they will continue to claim they have pain. All right, so we have positive reinforcers, which will aggravate pain, and we have negative reinforcers. And some of the positive reinforcers to those pains are, the more pain I claim I have, the more benefits I get from people around me. So you want to change that, all right? And the operant treatment of pain involves behavioral exercises to reduce pain behaviors and to increase healthy behaviors. All right, some people indulge in things that increase their pain, like smoking, all right, like alcohol. Some of them want to drown their pain away. So operant behavior technique makes them realize a change of lifestyle. Even, sleeping positions and all that, they can be positive reinforcers to pain. The other one is group therapy, which has been found to be helpful. All right, in the group of chronic pain sufferers, they are taught coping skills together. All right, pain educations are given to them, and they have social support among their groups. And it's before that this has gone a long way in reducing the intensity of pain among chronic pain sufferers. All right, sometimes invasive techniques may be used, all right, for certain types of pain. And I'm aware, I hope you're aware that epidural steroid is a common modality, invasive modality for management of pain, especially chronic back pain or other pains that, may respond to epidural steroids. Then we have what we call the spinal cord stimulation, also known as dorsal column stimulation, where it operates on the gate control of pain, where you cause a direct stimulation of large A fibers, producing analgesia. And this kind of closes the gate against smaller fibers, all right, and reducing the transmission of pain. Intracerebral stimulation, this is usually used only for intractable cancer pain, all right, and rarely used for other sources or other causes of pain. All right, these are the references. Okay, do we have any questions?